morning from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. We have part 3 of a series of webcasts done by Cyprian Ionita, a PhD from University of Buffalo, Jacobs Med. He's going to be talking about generally the interface between artificial intelligence and neurosurgery, an exciting topic nowadays. So welcome, Cyprian, and thank you.
Thank you for the introduction, John. So let me share my screen here. Right. Just a second now. This one, share. Okay. Can you?
Yes, we can see it.
Can you see this?
Yes, perfect.
So it's just a full slides, real-time surgical guidance using AI.
Yes, full slide.
Thank you. Okay, thank you. So today it's the third part and the final of use of AI for neurovascular interventions. And I started with the predictions or triaging of the patients, then with the complications. And today I'm going to kind of like go over potential use of the AI by the endovascular surgery. Again, my conflicts of interest are here. I have some NIH and NSF funds, and I have some patents relevant to this presentations. So the AI medical applications, as we said, at least into the endovascular procedures, we start first with simple things to help triaging patients and to help with stroke diagnosis, especially in the areas where there are a lot of patients or they have a lot of cases. And this in general is just for early identification of the patients and really for patients to identify those patients that are immediate risk and prioritize them. The next thing that we have talked about it is to detect complications during the procedures. With many cases and subtle changes into the flow, into the angiograms or images, there might be a chance sometimes that complications or small adverse events not to be noticed. And we think that AI in this case may enhance the neurosurgeon's practice or procedure by identifying these potential complications and flagging them. Again, this is not something that, let's say, the AI will fly solo and will take over as a procedure. It's just to bring to the attention of the interventionalist or as a neurosurgeon that something might be wrong into a certain area. And today, I'm just going to go over treatment planning and treatment guidance using the AI predictions. So again, this is a repeat of a few slides, are a repeat of the previous one of my previous lecture, part 2. I wasn't sure how many people have seen it, so I'll just quickly go over some of this. So the procedures that I'm focusing on are exclusively catheter-based procedures using X-ray image guidance, where the neurosurgeons takes the catheter under X-ray guidance, takes it to the area or a lesion is located into the brain, and using different devices usually tries to modify the flow into the lesion or reestablish flow, reduce flow, etc. So why do we want to do this? Well, it minimizes in general the trauma, the pain, the blood loss, and reduced wound complication. Is not very uncommon to see a patient released within 48 hours from the time of acceptance for some of these elective procedures. So bottom line, it is added safety to the procedures. Well, the issue with this is that some of the procedures that we do, the devices that we use are limited. We do not have ways to measure directly the effect of the treatment that we're doing. And a lot of these procedures may require additional or follow-ups. It's not uncommon for aneurysm treated with coils to see 2 to 3 follow-ups where coils are being added or due to incomplete occlusion, etc., or coil compaction. So I'm not sure how many in my audience, how many were trainees or residents. So, and I will go over this a little bit because they are the main focus of the presentation. For aneurysm treated with coils, a device like this is placed into the aneurysm, and the idea in here it is to use the structure of the device to reduce the risk of rupture by modifying the hemodynamics into the aneurysm dome. The need for this one is to have a narrow neck and in general, not to have the neck is actually in here is the most important part to decide whether to treat or not. The other treatment, it is a simulation or the simulating the concept of the flow diverter. This is not a flow diverter, but the idea it is represented in here that you divide a much denser device over here that will divert the flow away from the aneurysm neck. And there's different sizes. And if you're thinking about how the device works, it's like more like a finger trap. If you elongate it, the spaces in between the wire becomes wider, and the flow is less. And then if you're compacting it and bring it together, then the spaces in between the devices, the struts, the metal struts, becomes smaller and diverts the flow a lot. So there are neurosurgeons that are looking at this. And if the device, let's say you have a 3.5 millimeter device, they might oversize this or undersizing it. If you oversizing, and let's say for a 3.5 millimeter, you go over to the 3.75 device, you elongate it, and the pores in between become larger, so the flow into the aneurysm is less. If you go with a 3 millimeter device for a 3.5 millimeter diameter in here, then you have to crunch it together, kind of push into the device. And what's going to happen, you're going to have a higher density in here of metal over the aneurysm neck and divert more. The issue with undersizing and crunching it together, if you're not careful when you push onto the device, you will end buckling it into the aneurysm neck. So it requires a lot of finesse onto the neurosurgeons to kind of like feel the pressures into the catheters and the backflow onto the to avoid this kind of complications. So others that want to be safer, and they're saying, I don't want to, let's say, really fully occlude this device. I just want to make sure it's not going to grow. They oversize. In other words, they are taking a stent that is slightly larger than the device, and it's safer for them to deploy without worrying about the device buckling into the aneurysm neck. So once this procedure is done, the only way that we can look at these devices and figure out that something is happening, it is using digital subtraction angiography. And we can look and measure all sort of things in here. Stenosis, percent, intracranial aneurysm, so dome sizes, aneurysm neck, etc., to decide on the device that we can use, but not as much function. So here I'm showing you an example of an angiogram run. Here is a device, it is an aneurysm, and it was treated with that device, with a pipeline. These are the pre and these are the post treatment pictures. In general, the surgeon is looking at them and qualitatively is saying that I think I'm done. There is not much I can do in here. If decides that it's not done, some of them, like Dr. Siddiqui, sometimes places a microcatheter into this aneurysm dome over the pipeline before deployment and decides to drop a coil in, or decides to put a second coil in, or is wondering about it, you know what? I think this device, it doesn't have quite well the wall opposition, and goes with a balloon and inflates it slightly to make sure that the pipeline device is fully has fully opposition with the aneurysm neck. And based on these images, they have to decide. And as you can see in here, at 6 months follow up, this is gone. So what kind, the idea it is, what kind of the flow information we can extract from these angiograms in order to decide whether we're done or you should do something more about this treatment. And this is more so about coiling, because coils, you can deploy them in one at a time and decide whether you're done or not. And the idea is that if you're really deploy too many, or you're pushing too much, you might rupture the aneurysm, or you might end with a coil coming into the main artery, and then you might have to deploy a stent assisted coil embolization that will put the patient again onto the antiplatelet therapies. So there is a lot of implications with regard to the deployments. So what we want to do, it is shown in here. I showed this picture with the bottom part where we're deciding ischemia. In here, we actually want to do actually real treatment. And what I'm going to go today, I'm going to go through this upper branch in here. So normally you treat, you wait 6 months, and you see if the aneurysm occluded or not, and then you decide again to retreat. What we want to do, we want to deploy a software residing on the C-arm that looks at these angiograms, and then without any user interface or any kind of application from the user, finds the aneurysm right there. It goes, looks where the aneurysm is located, and um, then I think we have a little bit of a background, John. All right.
I
Thank
got
you.
it. I got it.
Okay. So and then not only finds where it is, it segments it out, which means takes only the area of the aneurysm and extracts those parameters out, and then it makes a prediction. And today my talk, it is about how we do this pretty much with AI, but I also want to show you evidence that all this data is supported. You cannot go to the AI and expect for it to do its magic and do a prediction that doesn't match our gut feeling, or not necessarily gut feeling, but our understanding, scientific understanding of the processes associated with this disease, with a particular disease. So the other thing that I'm going to insist at the end is that never ever use the AI to tell a surgeon that a definite answer and say, this is going to occlude. No, just give likelihoods of things to occur. Because let's say if the AI decides with 52% that this aneurysm is going to occlude, is going to give a definitive answer. And a 52% confidence into a prediction, it is not the same with a 90% confidence. So it is good for us to break the AI down and show the surgeons how confident is the software into that, and display it into our interpretation or predictions of the data. So let's go over the physics of it. So as I said, in the aneurysm, what we are trying to do, it is to use the contrast to decide whether we're done or not. And in here, I'm just showing you some data, scientific experimental data, flow data that backs that up. So we took phantoms like this you see in here a long time ago. We've been at this for more than 20 years. And I would say that the flow diverter concept also emerged partially also in Buffalo um, uh, in the early 2000s. So the device is placed across the aneurysm neck and diverts the flow. Here you see an untreated one, and you can appreciate here 314 millimeters per second, about 31 centimeters per second inflow impinging into the aneurysm neck. And then we use different flow diverters. Again, we can modify by how much it changes the flow in. And here is one that reduces to 5 millimeters per second, and another one that reduces to about 2.9 millimeters per second. Also, the vorticity inside dropped from 100 seconds to -1 to 1 second to -1, and so forth, to order of magnitudes. And now when we look at the X-rays, you see these are the velocities. And how do we know that this is right? It is because we measure them, and this is kind of showed the concept. We pass these particles through those phantoms that I showed you with a laser. We shine the laser, and we track small particles all around. All these particles are being tracked, and then gives us measurements like this. So we know exactly the flow, how it goes in. And when we look at the contrast, how it goes in, it exactly follows to a certain degree. The flow is from down up. You see the vortex, and then it goes from here. And as again, you see like it comes at the neck, goes out, comes as the neck and goes out, not quite like here. And here you see it goes right at the neck in, sips in, and goes out, exactly the same. So the key point that I want to make is that yes, the contrast follows the hemodynamics up to a certain degree. So we have to go, and when we look at the contrast flow, we can trust it. We can trust that the patterns that we are actually see are related to the hemodynamics and the hemodynamics changes that come into the flow. The problem it is, if I'm asking a person or a surgeon right now and tell them, is this going to occlude or this one is going to occlude? Because this is not available. These velocities, forget it. They are not going to be able to for us to measure them into the aneurysm when we use the devices, because there is a bone in the way. We cannot use ultrasounds. We cannot have any means to measure this kind of velocities. And this is where the bottleneck or the problem is. If we would measure these velocities, we don't need AI any longer. But the situation is in such a way that we can't, and the only way we can look at these processes, it is through the digital subtraction angiography. So how we do that, I told you before, I'm just going to go really briefly. We look at uh, things like dye dilution curves, and as the contrast propagates through the system, they tend to spread really, and this is exaggerated. They are the differences are slighter. I would say something maybe between and this and that occurs, but we can look at these parameters and figure out what are and infer kind of like uh, estimate what hemodynamics are going in there. And we measure these quantities, which are very common for the people that do CT perfusion to evaluate stroke: mean transit time, time to peak, peak height, etc. Mathematical formulas are given here. We're kind of old school in this one. We're using the gamma variate functions. A lot of in the CT perfusion now, the more advanced techniques like like SVD plus and Bayesian algorithms are used to evaluate those flows. And it just goes exactly like in CT. You take the data, you do some processing to make it faster. You look at every single voxel, in this case pixel, derive this kind of curves, you speed it up, do the analytical function feeding, and derive the parameters, and then do this for every single one into the image, and you get pictures like this. So again, these pictures are as you're looking at the flow with different filters, and every single filter gives you a different kind of information. For the mean transit time, for example, is the average time a particle spends into a certain area. Time to arrival, it is how fast it got there. Peak height is almost like cerebral blood volume. And for the artery equivalent, how much contrast gets into a certain area in this case. So an area under the curve, it is a combination of the mean transit time and peak height. So the question is, are these parameters related to the hemodynamics? I show you that the patterns are, but the values are. The question is, are they related? And here we did again lots of experiments where we really confirmed that mean transit time, bolus arrival time are related with the velocities because we have pumps that can control this. We have ultrasound. We can go into that our region of interest area, measure it. This is all benchtop kind of experiments, and we know that it goes. And look at this for different flow rates in milliliters per minute or in centimeters per second measured at that area, we see that there is direct correlation between bolus arrival time and mean transit time in there. And these are very repeatable. So what is the problem? Why we cannot have just a mean transit time at some point really tell us what's going on? You take the mean transit time correlated with the disease, with the outcome, and things will go easy for you. The problem is this. Nobody is going to inject with an automatic injector and in the same center. And no, and across different centers, it is even more different. And if you look at, let's say I have in here an automated injector and I did do 5 milliliters volume and I do a 10 milliliters per second. I'm sorry, a different injection rates, 5, 10, 15, and 20 milliliters per second. And we're looking at this situation in here, at this aneurysm. What are the mean transit times? And there is a huge variation in here because now if I have a center and say, hey, this surgeon in here is injecting 20 milliliters per second at a 10 milliliters volume, and another one somewhere else is injecting something less at 5 milliliters, and so they're going to get the same mean transit times. And here, what we did, we place a stenosis. And then he's going to conclude that the patient with a stenosis has the same kind of hemodynamics as a patient without stenosis, which is entirely different kind of hemodynamics in there. Again, injection parameters or the hand injection, it is extremely important and it will skew the data to the point that you cannot relate an angiogram from one center to another. Hence, we need to take care of this. And we have developed something that is called an SVD, which is single value decomposition correction, where you have to go for the ICA. You take really the arterial input function like you do it in CT perfusion, and you fix for it. And not only that, that we flatten it and we say, this, what it actually, this process, what it does, it is simulating or bringing the data as if you do a hand injection with a delta function. That's what it is, which means a very short injection with very and a lot of contrast. And as if everything happens in a fraction of a second. So it brings variability to that type of injection, simulated injection and the parameters. And what I want to point out is that stenosis versus, in this case, versus non-stenosis, a big difference in between them. And it's independent on the milliliters per second, and in the same way, it's independent of the volume. The volumes are they are overlapped. Again, this is stenosis versus non-stenosis. Now, with a mathematical process like this, we can start seeing we reduce this variability that doesn't make any sense. We want to just take hemodynamics of the lesion and in the same time takes away some of the corrections. And I will show you why I'm going through this because it's extremely important. It adds a variability which limits our ability to predict what's going on. And then if we add the C-arm changes into the play, then it's going to be even a bigger problem. And when we have these variabilities or these inconsistencies in the acquisition, we are not able to do our job properly. So what we're going to do, we are going to go back. We're going to start looking into things like AI or data-driven models to help us overcome this variability and patient variability by looking at lots and lots of data in order to solve the problem. So the current status that I will show you today of our AI technology is as follows. It detects the lesion, in this case the aneurysm. It goes and extracts the parameters. Then it predicts outcomes. And again, here I have to make sure that I make myself clear. This is not outcomes like yes or no. We are thinking as engineers when we started this, and we like. Can you stop that?
Почему?
I'm sorry, I'll get that. I'm sorry. Okay.
Можно же вниз.
Okay.
Thank you.
Okay, that's
Thank you.
fine.
And again, it's not about prediction of the outcomes. It is actually likelihood. When we started in the beginning, where as engineers, we wanted to predict everything and tell everyone that this is the ground truth and so far. And as we talk to more and more of you guys, we realize that we have to step back and step back and step back and actually behave like physicians, give you likelihoods and so far. And then also the protect against complications. Let's say a wire might go through the aneurysm neck and creates a subarachnoid hemorrhage, and a predictor, let's say, of something like a delayed cerebral ischemia. So first of all, how we tackle the aneurysm identification, or how do you do for lesion identification? And this you can apply again for any kind of lesions. You can do for AVMs, you can do for intracranial disease, stenosis, and hemorrhages. So we took 350 DSAs, and again, this is our limitations. We're working on one center. It is only Canon. It's Canon equipment at Buffalo Gates Vascular Institute centers. We use only adult patients treated for sacral aneurysm with coil or pipeline, and and we're using, as I said, Canon Infinix biplanes for everything that we do. If you're wondering about the distribution, 55 prior for treatment, 45 following coil procedures or pipelines, and these are the distributions. We went really from mostly in the internal carotid, and we're very limited, like in our studies on the basilar and posterior cerebral circulations. We also use 45 true negatives. So poor image quality, it is a big problem. Things like this immediately throws the AI off. Even an aneurysm like this, if you're not careful, the AI might be actually be thrown away. So one other things that AI could be used in these cases, it is actually fixed for this kind of artifacts. And then what we did, actually, we processed every single sequence to increase the signal of the aneurysms neck. And then we had the neurosurgeons or fellows, not the actual attendings, fellows and non-residents and scientists, go through every single one and hand contour the aneurysm. We can have an automatic feature that can segment all the arteries in here, but for lesion itself, it is very good if you have somebody go and hand contours it in order to make sure that that the data is right, and it better be an expert in the area. And now, as I said, since we are one center, this kind of data is not quite good for us for the training of the AI, and we need into the thousands, and that's why where collaborations come very, very important into this. I would say if you want to do an AI that is relevant to many centers and many a large population segment, you need collaborations with different centers. So in order to bypass this, we really did we cheated in a way, and we did rotations, we did zooms, we did a little bit of data augmentation, what is called, by messing up or changing the images, and we made sure that when we crop, the aneurysm is not out, like in this case, so it becomes a true negative in this case. And then we we got 1,500 examples, and 600 we kept for testing. In other words, these guys in here you never touch during the training of the network. For those interested into the details of the AI structure, we use Keras, and we use what is called a VGG16 architecture. And this one was developed really for detecting or type of objects onto the internet pictures, labeling pictures onto the internet. And what we do, we kind of like look, you train the networks, and as they are being trained, this parameters that you see in here in convolution 1, 2, 2, and so far, all these segments are the weights or the experience of the AI is being set. In other words, we're going to go and we take those pre-trained weights on existing data that is out there on the internet, and we start with those and apply them to our images. That saves us a lot of time in order to do things like segmentations and so. This is about 3 years old. I think no, 2 years old, and it was awarded at the SPIE Medical Imaging in 2019. It received an award. So since then, we improved this method. Again, for people that are interested into details, this is what we used at that time. We use an ADA delta that adapts learning rate over time. We did transfer learning, as I said, from ImageNet, and in order to calculate this, we use to calculate the efficiency or the accuracy. Use what is called this dice to optimize. I'm sorry, we use a dice loss. For quantitative analysis, we're using the normal area under the curve, but also Jacquard Index. And how do you read this for those people that are not familiar with it? It is, you have two shapes. In this case, this green stuff, this green square, it is what, let's say, the expert labeler has done. And the red one, it is what the AI comes up with. If you get something like a 0.4, it is a poor match between what AI predicts and what the labeler has done. This is a good agreement. An excellent agreement is usually you're looking somewhere into 0.92. For clinical applications, you must be somewhere in this area and above in order to do the segmentation. This is another coefficient that we have used. And uh, uh, we used also this network next to determine where is able to extract those parameters, those flows parameters, those angiographic parametric imaging parameters, to see if it is able to extract them, and we compare them again with some with a expert user. We had, for every single case, we had an expert go and extract the parameters like mean transit time, time to peak, and we compared the AI with this expert user to see how it does using Pearson correlation coefficients. Here are some examples of the results in here. You see, we start with an image like this, we have a sequence of data like this. These are hand contours, and you see the user usually places a circular ROI, and he places also one here to take into account those variabilities because of the hand injection. And as you see, this is done. We don't need this to be done with AI. We can do this automatically just by image analysis. So I will focus only onto the aneurysms. And you see here how the AI has done a pretty good job at the aneurysm, but the distal part onto the arteries, it's so-so. So in general, it's good agreement between this. And if we use coils, again, there is no problem. Very good agreement between what a user will do and what the AI will segment. I would say the AI actually is better because it doesn't do this kind of circular placement. It goes and identifies the edges. And the thing, it is slight motion artifact, it is okay. It is not being thrown away. If the patient has, in this case, this patient had a intracranial hemorrhage and he had a craniotomy, as you see in here, to in a shunt placed. Again, no problem when you have hardware like this in here. Highly attenuated structure is not throwing it off because it has been trained only to look at this kind of data and can easily ignore those. Other things like you see again another example of a stent assisted aneurysm. The stent, you cannot quite see it well in there. Um, Catheter presence, no problem. It can ignore it very well. Area under the curve for aneurysm neck detection or the aneurysm sac detection is 0.798. When you look at the Jacquard indexes, it is into the area. Again, this is overlap, dissimilarity coefficients, area under the curves. They are into the clinical area acceptable, and confidence interval pretty tight nonetheless. For vasculature, in here, it is on the bottom. What we're focusing in general, it is over this values, dissimilar coefficient, similarity coefficient, which is really good. We like it. However, for the area under the curve for the vessels, it is a problem because it's trying to segment this low signal data in here, and it's poorly enhanced. So, but again, we do not care when we look for lesions. We do not care about this artery in there. So the peripheral vascular, which is very small, is not a problem that really um, is not does not segment it very well. I care about what is here, and in the area where the aneurysm it's segmented, it does very well. Now the question is, how does the AI does in extracting those parameters: bolus arrival time, time to peak, mean transit time, area under the curve, peak height, and the error, it is 0.2% between the AI and the human. All right, so correlation, again, superb. It's Pearson coefficients almost, except for bolus arrival time, it is pretty good. It's a very strong association with the API values. Now the thing it is, let's say what we're saying in here, it is that the AI performs non-inferiorly to an expert user in taking these parameters. However, unlike manual input where you have to load the data, look through them, do that, which can take anywhere for somebody that is not quite an expert can do 20 minutes to extract and save that data. At the time when this was done, it was 5 seconds. Right now, it is zero point 0.5 seconds in extracting the data by this AI, which means it happens almost instantaneously. After every single angiogram, this software or this approach, this AI approach, can go and extract these things. And really, what does this open for us? It is to be used in the clinical setting, extract those parameters, and actually perform some sort of prediction of the outcomes or the prognosis of the outcome. And right there in the engine room, instead of waiting at the 6-month follow-up, to allow the surgeons to do the adjustments. So here are some situations: case A, case B, case 3, all treated with coils. And what we see the cases before, and then we see what's happening after. And when we ask them, well, is this going to occlude or not? And the idea is that at the end of the day, you see in here, one of them is totally gone. One of them is partially. And this one, it's pretty much there. Not only that you have the neck and regrowth, but you have also into the dome. The same thing applies for the flow diverters. Here is the aneurysm. Here is a flow diverter. You kind of like see it in there, depending on the screen on your the resolution on your screens, and then the aneurysm is gone at follow up. Case B, 5 aneurysms on this patient, one big pipeline that went from there all the way down, blocking every single one. All of these guys gone. This one in there, depending if you look very careful, it is some sort of a seepage in there. But in this guy in here, here is the aneurysm. Here is the after the treatment. 6 months later, nothing happened. So the question is, can we tell them at the treatment whether they're the surgeon, or what is the likelihood so to allow of occlusion, so the surgeon can do an adjustment of the treatment, or at least put that patient on observation, because something like this, you might end with it rupturing. So the way we are doing it is we are taking these parameters, and we're taking parameter before and after the treatment. We always do a baseline comparison. And then we are looking at this 4 maps: time to peak, mean transit time, peak height, and area under the curve. We have done this over a few hundred cases to train our networks. The first module of the API, or the AI, takes the data, passes through a deep neural networks, makes the prediction, and then here it says with an 81 probability that this aneurysm is going to occlude. And in this case in here, it said with a 99.8 probability or confidence, this aneurysm is not going to occlude. And indeed, when we looked at the 6 months follow-up, the aneurysm was there intact. So what you need to know is that you need to address this, and this is where we spend a lot of the time. 2 to 4 years we spend on how we make sure we account for everything. So because into the AI, junk in, junk out is going to be, if you're not and this is where is our proprietary method. And you have to kind of like figure make sure that, look what is happening as the prediction of or the accuracy. If you use raw data without any processing, without accounting for hand injection, without accounting for C-arm orientation, and so you're getting a flip of a coin, worse than a flip of a coin. Now, when you correct for injection, you get into 0.67 area under the curve. When you do also account for C-arm orientation and for shortening, you get into the 0.77 area under the curve. And our interface, as it is, the one that we have developed right now, what it does is still manual. We hope this will be on a C-arm. It just goes, loads the data, then automatically, without the surgeon interfering, finds the aneurysm, extracts the arterial input function, and then it predicts what's coming on. And it gives in here, right there, displays the maps, says probability of unsuccessful treatment in this case is going to be 79.9%. It gives you how the values, tries to do some interpretation and say, hey, before the treatment, you had a mean transit time of 1.08. After, you have a 1.04. Your mean transit time went down for the area where the particles went in. That should be immediately a sign for you that particles spent less time into the aneurysm zone than before, even though the peak went from, let's say, from a 0.819 to a 0.78. So the peak has decreased by 10%. You see less contrast goes in, it gets out faster. And the signal should be, hey, this has a problem with wall opposition, or some, so the way I diverted the flow needs to be reassessed. I will end with where are we going next with this? And we want to add even more physics into it. So you remember that I said that the AI just tries to find this function that takes the input to the output by comparing it with a graph label, and is just comparing them over many iterations until you get you show apples and it says it's apples. But now in here, we're thinking to go one step farther. And it says, hey, for this kind of flow, add some physics into it. Let's put in there things like mass conservation, conservation of momentum, conservation of energy into those decisions when we optimize this. And it's, do not worry about the equation, it's just examples, doesn't mean absolutely nothing. But we can take stuff like this and say, these are the rules that in this gray area must be followed. These are the rules that the physics or the contrast that you see must follow. And we take that and we make like a loss function It's what we minimize, the error that we try to minimize. And then we tell them again, boundary condition. Outside the gray area, everything is 0 on these areas. And when it comes in here, you have to have these velocities. You kind of like go and you add every single physics phenomena that you have into this huge term in here, and then you put it to go to 0. So when you train the AI, you tell the AI, hey, minimize this function instead of minimizing the error between the values that you have and the things and the expert users. And the thing it doesn't matter what you're doing, because even with the simplest of the AI, you always calculate these values. You always calculate derivatives in order to minimize your function. And here, what you see is almost like a real-time predictions of, in this case, the velocity into this direction, velocity V is into the Y direction, and the pressures. And imagine until now, these are simulations, by the way, but imagine until now, in order to extract this kind of velocities, what you did, you put into something called computational fluid dynamics, which can take 48 hours to calculate. What about having something like this? As soon as you upload from your data into the surgery, you upload a picture like this, it starts calculating those values and tells you what is happening. So we're moving even one step further when we can do physics inform artificial intelligence. So I'm going to end this. This is a big back to the big picture. We're into this domain. We're looking at stroke protocols to triage the patients. We're looking at actually detecting in real time if complication has happened, and we're trying to predict as well if a surgery is going to be successful. This is, in a way, the big picture is in here. In order schematics, there's 2 AI units residing on the C-arm. One of them is looking at identifying the lesion and predicting occlusion. The other one tries to detect area of delayed ischemia or acute ischemia, telling the surgeons that something is going on. And we want to do this without any kind of disturbance into your workflow. The idea this has to be as stealth as possible. We need to work with Canons and Siemens and Philips and GEs, and I'm sorry if I forgot any of those others. We need to have this software working on their CRM to actually help you in real time. Without them, forget it. This has absolutely doesn't have a value, because you're not going to step out of the surgery room, really look at a software on a laptop and go back in. It is just not going to work. So with that in mind, these are my collaborators. Every single idea that we presented that in here, it is done by the engineers, but it has been initiated by this gentleman. Dr. Siddiqui, Dr. Levy, who's the chairman of the neurosurgery, Dr. Ken Snyder, and Jason Davis. These are their patients, and they come with the problems to us, and then we try to solve. And these are actually the folks that write the code. They go stay in the M&M meetings. They go to endovascular planning meetings and discuss, just listen to the neurosurgeons teaching their fellows and the residents, and then they go back and write those codes that I've shown you today. With that, I think this is where I end the discussion, and thank you, John, for allowing me to give these 3 presentations over the last 3 weeks.
Yeah, thank you very much, Cyprian. And it's great to see those engineers interacting with neurosurgeons to make the project go forward. Okay, we're open for questions or comments.
So Cyprian, thank you for your nice presentation, and it's really fascinating. But you know, the aneurysm rupture rate is correlate with energy loss according to the Bernoulli's principle. So can you calculate the energy loss when you do the angiogram? in the spatial segment of the
to calculate what loss?
energy loss.
Energy loss.
Yeah, like
Yeah.
the dynamic energy.
Yeah.
Yeah.
So
Because you know
this,
the local energy loss may be the cause of the rupture of the aneurysm.
as this is the work of my colleague Dr. Hui Mong. He has put a lot of time into this, and she's calculating these risk rupture scores. And that's something they're looking into it. And they also went to the AI because to account for huge variability into the data sets that they are seeing. Until now, a lot of the computational fluid dynamics have relied on idealized boundary conditions, those conditions that I said what's happening at the input and the output, which is not the case. Every patient is different. Every patient has different input hemodynamics conditions, and they are looking to use this AI to improve their CFD. And since it is about aneurysm rupture prediction, it is not really imminent to happen in real time.
Yeah.
We can take a CTA, preferably cone beam CT on an angiogram, and then use that. And that's like really, really very hot topic for them. Use the AI to extract boundary conditions so we can make our CFD better.
Yes, thank you.
So it is. You just nailed it right there.
Yeah.
We spend a lot of time into that.
Yeah, just as you mentioned, the idea stent should be partially high density metal rate to cover the neck of the aneurysm.
Yes, would be. Hopefully, somebody from Medtronic will see this and listen to what you have.
Yeah.
Oh.
Okay, thank you.
Okay, thank you, Ben. We have a question from Mohammed Helmi, a neurosurgeon from Egypt. Greetings from Egypt, exciting lecture by Professor A.E.I. Unita. I wonder why didn't you apply this technology more to the posterior circulation aneurysms? As you know, the post-circulation aneurysms are less debated to undergo coiling versus clipping.
Yeah. So first, the pipelines that we really focused a lot because it looks like that the field is going to that direction. They're mostly into anterior circulation. Now, every now and then, if you go for a pipeline into, let's say, into the basilar artery, it is like asking for trouble because of all those perforators in there. As far as concerned coiling into the posterior circulation, we are actually doing that. Some of those results for segmentations are for posterior circulation, and so. But as I said, we really use one single center, and we see that whenever we're wrong, it is very likely to be wrong about posterior circulation. So more data into posterior circulation in collaboration with others to make sure that we have a uniform data set will be really awesome. We don't have just enough in our centers, center enough for posterior circulation. So and I'm not answering your answer really, but we do not spend that much time because we really don't have that much data into that space also. So anyone that wants to work onto this, we are more than open to.
Yeah, so you're looking for data centers, correct? To supply that data. So
in collaborations, and I understand that everyone is tied by these IRBs and the rules, which are really draconic everywhere. And I have like really no easy solution other than have you know, bigger organization like National Institutes of Health putting out these challenges where different centers can contribute to create these data sets or so, or otherwise having just us collaborating is going to take a much longer time. They can snap their fingers and all of a sudden 60 to 100,000 cases materializes, like RSNA does it all the time. In the neurosurgery, we don't have that.
Okay. Okay, we'll work on that. Okay, more comments or questions from the panelists?
Yes, I think the aneurysm rupture prediction is a very hard work, because it's not only correlated with hemodynamic parameters, but also the surrounding structures like CSF, like the cortex, the nerve, the neurons, and everything surrounding the aneurysm dome.
Yeah,
it's
the wall imaging. It is like the really hot topic now. With the MRI is looking at wall imaging and bringing that into the model. It's also very important for here.
Yeah, so you are also doing that work?
Yes, we are collecting wall imaging data for as much as we can right now.
Okay, great.
Mm-hmm.
Very good. More comments or questions? Okay, great, Cyprian. Appreciate it. The time you took for the three, and we'll have it edited and sent to you and be archived. And thank you, Ben, for coming. And Rosanna Romani, do you want to say hi from Argentina? I don't know if you want to say hi. Maybe I'm embarrassing you. I'm sorry. Okay, anyways, thanks everybody for coming, and we'll end this now.
Thank you.
See you later.
Thank you.